So we're going to talk about medications affecting blood pressure. Um, we discussed in patho how blood pressure is controlled. Um, we have our mean arterial pressure, which is dependent on heart rate, stroke volume, and peripheral vascular resistance. Our autonomic nervous system consisting of our parasympathetic and sympathetic branches control vasoconstrictions and heart rate. The baroreceptors, those are like our stretch reflexes. They detect pressure changes and signal our brain to make changes. And then the RAAS, we know that involves hormones and controls blood volume and the vasoconstriction, vasodilation as well. Okay. That is very important for you to know because the medications that we are going to cover are going to cover some portion of this control of our blood pressure, which makes sense. If this is what makes our blood pressure happen, I need to stop. If something raises my blood pressure and I stop that, what's not happening? Blood pressure raising. Okay. So understanding that is going to be important. I'm not going into depth on all of these things because we did just cover them. But I will touch on stuff that I feel like is important for you to know. Okay. Um, this is really just another reiteration of that information. If there is some disruption in brain function, in that hormone control, in kidney function, in change in our vessels, or with those baroreceptors, there's going to be alterations in our blood pressure. And that could cause hypertension or hypotension. Okay. Um, the renin angiotensin aldosterone system. Tell us what it is, Kiera. Mm-hmm. Mm-hmm. Uh-huh. Mm-hmm. Mm-hmm. Converting. Mm-hmm. 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 Look at her. So, very good. I'm very proud. And it is helpful to understand that because a lot of the medications that we are going to discuss are going to affect some portion of that RAAS. Okay. And so understanding where it's affecting, understanding what it's stopping, what it's targeting will help you understand why it has the desired effects and what the potential side effects are. Like she said, one of the effects of ACE inhibitors, which we will talk about, is a non-productive cough. And so you could just take that at face value. Great, they're going to have a non-productive cough. But it is helpful for you to understand this is what's causing that. This is what is triggering that non-productive cough. And because of that, If that is aggravating to them, we can give them a medication that affects something lower down in the RAAS, and then that will get rid of that cough issue, okay, if it's bothering them. Um, that's an ACE inhibitor. That's right. Um, and we'll go over some of the specific medications. And so once there is increased blood flow to the kidneys, that should trigger the renin to stop being released. What happens is with hypertension, your body kind of gets tricked because blood isn't getting to the kidneys the way that it is supposed to. And so on top of your blood pressure already being high, then your kidney is sensing that the blood flow is low, so it's releasing more renin, which is triggering more of this response. And it's kind of just a cascade of things that can occur. Same thing when somebody has kidney failure or something that is interrupting their blood flow to their kidneys, that can cause an increase in renin when maybe blood pressure isn't necessarily what the problem was. Um, let me see if there's anything else that I wanted to tell you. I think that's it on that. Okay, here's a little picture just going over all those same things. Um, Antidiuretic hormone also plays a role in this little system. And so this is going to cause vasoconstriction as well as fluid retention, which is helping to stabilize that blood pressure. Okay. So if I'm giving somebody a diuretic, I'm counteracting and getting rid of that excess fluid. Okay. Um, I have a note here to look on page 43 for treatment recommendations. Um, we Hypertension, the definition of this is just that their blood pressure has been elevated, not just a one-time occurrence, okay? Most of the time, I think I told y'all this before, there has to at least be 3 different instances where that has been recorded. There is a potential for this to cause organ damage to their heart, kidneys, brain, eyes, blood vessels. And we remember that this is dangerous because they might feel just fine. They might not be having any symptoms. And so they take these medications that cause them to pee or cause erectile dysfunction or cause them to cough repeatedly. And they're like, I was doing just fine before you gave me this medicine, and so I'm not going to take it. And then all of these negative things are happening behind the scenes, and they don't realize it's severe until usually it presents as something more serious. This can potentially lead to atherosclerosis and thickening of their heart muscle. It is important for us to detect this early, and the earlier we treat it, the less likely they are to have serious issues. It is important for them to be compliant. So assessing for those side effects will be important. Other things that could occur are renal failure, stroke, coronary artery disease. Again, important to teach patients that these are potential complications to encourage them to be compliant with their treatment. Things that put them at risk for hypertension, getting older, a family history, high intake of salt or alcohol, sedentary lifestyle, cigarette smoking, obesity, if they have obstructive sleep apnea, if they are just exposed to high stress or anxious, or if they have insulin resistance. When somebody has hypotension, there isn't enough blood pressure to accurately get circulation and perfusion to the rest of their body and their organs, okay? If this is prolonged, it can lead to shock. It could be caused by damage to their heart muscle, blood loss. They could have some autonomic issue that's affecting that neural trigger for their blood pressure to be controlled. Or this could be side effects of medications. What medications do you think could cause hypotension? Something I'm given to lower their blood pressure, right? So that I could have, that's what I wanted to happen, but it can do it too much. Okay, so it is very important for them to continue to monitor their blood pressure while they're taking this. And then orthostatic hypotension, y'all remember what that is? And do y'all remember how I check for that? So I have them lay down, sit up, stand up, and I do that within like 3 minutes of each other and recheck it each time, right? And there is some parameters, and I would be lying if I told you what they were, but look it up. But there are parameters on like the degree or how much of the change that occurred, and I don't remember what it is. Do you know? I want to say 10, but I'm probably lying. I don't. Yeah, that sounds right. I really don't remember. But any change, and then more importantly, do y'all remember what I'm focused on more than what that little blood pressure cuff is telling me? Yes. Are they dizzy? Did they pass out? Do they feel weak? Are they having symptoms? Okay. And so if they tell you that, falls are going to be something I am concerned with. I'm starting by telling y'all all this because there is, we talked about classes, which I'm going to get into specific classes of things that decrease and increase their blood pressure. But we also are just talking about antihypertensives in general, right? If I am giving somebody to affect their something to affect their blood pressure, there are going to be things that are just fall in that category. Okay, so a lot of times when we learn about this medication, that's what it's medications. That's how it's going to be. We're going to cover as a whole and then get more specific into different things. Okay. Um, so if somebody's experiencing orthostatic hypotension for whatever reason, or just hypotension, period, it is important for me to monitor or implement safety type precautions, right? I don't want them to fall down. I don't want them standing up without assistance. They can sit on the side of the bed, dangle for a few minutes before they get up. All of those things uh, are safety measures. Um, what happens when somebody isn't getting enough blood flow? They are going to have every single body system is going to be impaired by that. Okay. Um, things that they might look like, they can have dizziness, weakness, confused, they may have cold extremities, and they could even lose consciousness. And that term there is syncope, where they fainted. Okay. Um, People who are at risk for this is going to be more common in older adults and people who are taking medications that put them at risk. So anything that's affecting RAAS, aldosterone, ADH, are going to put them at risk for hypotension, or orthostatic hypotension. Other things that can cause that are like sedatives, opioids. I'm sure there's other things that I'm not thinking of, but certain medications do put them at risk. Also, if somebody's on prolonged bed rest or they are dehydrated, that can increase their risk for that. Sometimes your patients are going to be on diuretics, have some sort of neurological issue, been on bed rest and dehydrated. So in that case, they're going to be at an extra risk of orthostatic hypotension. So we monitor their vital signs, teach them to change position slowly, and make sure that they are hydrated and safe. I'm going to try to turn this off, so sorry. Okay. For all of these things, in most of the PowerPoints, I've put the picture from the book. You have access to this full thing in the book. That is harder to read there, okay? I will try to point out specific type things that they say, but know that that is something that you can refer back to. So for children, they should use diet and exercise first. If that doesn't work, they'll start them on medications. Most of the time, they'll start them on beta blockers as their first medication. But sometimes, just depending on what the kid has going on and what their issue is, they could use calcium channel blockers, ACE inhibitors, or ARBs. Regardless of what age they are, teaching is important. We want to make sure that our patients are staying hydrated because that puts them at risk for hypotension. If there's changes in the weather that can affect their blood pressure, and dose adjustments may be needed. If somebody is pregnant, they cannot take drugs that affect the RAAS. Okay, so that is going to include ACE inhibitors, ARBs, and renin inhibitors. As far as pregnancy, calcium channel blockers and vasodilators are not recommended and should only be used if the benefit outweighs the risk. And that can get in breast milk. So in that case, we would want to teach them that they need to supplement or use some other sort of nutrition for the baby. For pregnancy, labetalol is usually what is used. It is a beta blocker. And then during pregnancy, they will use magnesium. In fact, they can develop preeclampsia, which is elevated blood pressure while they're pregnant. And usually, I don't want to say usually it's close to delivery because that's not the case, but magnesium is usually what they use to treat that. As far as older people, they are going to be more at risk for those negative side effects. They may need dose adjustments, and then medications that they have could interfere with other, the medications that they prescribe could interfere with other medications their own. And then just because they have that slowed down metabolism and excretion, they might need dose adjustments. And then if somebody has some sort of kidney or liver issue, also they may need dose adjustments. Elderly are also more sensitive to fluid loss, so they are at an increased risk for dizziness and syncope, so falls are going to be a huge deal. Regardless of who you're giving medications to, if you are giving something to treat somebody's blood pressure that could potentially affect, let's just say, their blood pressure, their heart rate, their urine output, what do I want to know before I give it? So if I'm giving you medication for your blood pressure, what do you want me to know? The blood pressure is, right? That would be a good place for me to start. And baseline is important. And so when somebody comes into the hospital, and this will matter, I'll tell specific parameters for certain medications, but what is a normal blood pressure, quote unquote? 120/80, okay? So let's say I have a triple dose of what somebody normally takes, and I am getting ready to come give you your blood pressure medication, and I take your blood pressure, and it is 120/80. What am I going to do? Why? Why? What would help me make that decision? Critical thinking, 100%. What else? What it what it was yesterday. If I have access to that, that would be great. So if yesterday their blood pressure was 180/95 and somebody gave them these medications that I'm getting ready to give, and their blood pressure went to 90/60. Am I going to give them this morning? Probably hold it, right? Because that was a drastic jump. But if yesterday their blood pressure was 112/70 and somebody gave them this medication and then they checked it again and it was 110/65, easy decision, right? Because it probably is low or normal because they're taking their medicine. And if they don't take it, I'm going to have a problem. Okay? But it does, all of those decisions require critical thinking. There is no way for me to give you a cookie cutter. If it's this, don't do it. Because there are a lot of things that go into that. There also, with the elderly, there is risk for polypharmacy. So we want to make sure that we ask questions about if they take this at home. And I've made decisions based off of that too. If I'm getting ready to go give somebody something, I'm a little like, I don't know that I want to give them this. I don't know if I should. And I say, how long have you taken this medicine? And they say, 17 years. And I say, how often do you check your blood pressure? I hadn't checked it in 6 months. I'm probably giving it to them, right? Like they don't even check their blood pressure at home. Now, depending on what it is, if their blood pressure is 80/40, I'm not giving anybody things that are going to lower their blood pressure. Does that make sense? So all of these are just critical thinking in the moment, decisions that I'm taking in assessments, I'm taking in the patient's history, I'm taking in what medication this is, how I know how quick it's going to act, what I know it's going to affect. And sometimes the decision that you're making is this, they have 2 blood pressure medications ordered, and I know that this medication usually drastically decreases somebody's blood pressure and it doesn't affect their heart rate. This medication may mildly decrease their blood pressure, but it's going to drastically decrease their heart rate. So if I'm getting ready to go give somebody these 2 medications together and I'm a little scared of like, I don't know which one of these I should give or if I should give both or if I should hold both. If somebody's heart rate is 120 and their blood pressure is 110/60 and I'm making a choice of what I need to give, in that case, what would I want to do? Their heart rate would be more of my concern, and it might affect their blood pressure, but not a whole lot. And I might hold that one that's going to lower their blood pressure a whole lot. Does that make sense? And so all of these are just decisions you make all day long.
And I think that's correct. Um,
Mm-hmm.
well, take some blood pressure. Oh, my blood pressure is 122/76. I'm not going to take my blood pressure medication. I'm like, you are.
Mm-hmm.
He said, "Oh," I said, it's normal because you take your blood pressure
Yeah.
medication. Doesn't it?"
Yeah. And that is important for you to know. It's important for you to know, like, this isn't going to cure you for life. This lasts for this amount of time. And so if I don't take it, it's going to quit working. It's not going to do its job. And sometimes what ends up happening is I might hold it for 2 hours and I give it later. Sometimes that is what happens. But it really just depends. So we're checking vital signs right before we give it, especially if there's anything that could be affected. Blood pressure and heart rate usually very important for you to take. And then if they are extended release, I'm not crushing or cutting or doing anything like that. I thought of something else when I was saying that. Take their blood pressure, okay. If I'm giving somebody a diuretic, what do you think I want to know? Their urine output. Very good. Are you urinating? What does it look like? Is it more frequent? Because if I've given somebody a diuretic and they're not urinating, there is a problem. Okay, there is something going on. And so I need to know that it is doing its job. I also would be worried that they're dehydrated or, that they're losing too much fluid. All right. So as far as deciding treatment for hypertension, I have a note here that on page 745, there's box 43.1 for treatment for hypertensive medications. Generally, our number one thing we're going to start with is if you can do things outside of medication to prevent you from needing meds, that's what I want to do. Okay. So we'll encourage exercise, losing weight, fluid, sodium restrictions, whatever. Next, they will start them on a blood pressure medication. Okay. This really depends on what the patient has going on, and a lot of times the first thing that they are going to try is a thiazide diuretic. With any antihypertensive medication, generally they're going to start low and go slow. So they're going to start on the lower dose. They're going to see how the patient's tolerating it, see if they're having any adverse effects, see if it's affecting their blood pressure the way that they would expect, and then they may increase the dose. They may decide to choose a different medication. They may try to just add another medication on. It really just depends on how the patient is responding to that, okay? And so even that could be education that you were providing to the patient of like, if you start with exercise, diet, trying to avoid salt, you could end up not having to take medications at all. And then if you're not compliant with treatment, you're going to have more doses, more meds, whatever, okay, which come with more side effects. All right, so this is your classes of medications. Again, the way that these work are all a little different to affect their blood pressure. So ACE inhibitors, that's blocking that angiotensin converting enzyme, which is blocking the conversion of angiotensin 1 to angiotensin 2. The angiotensin 2 receptor blocker, or ARBs, block the angiotensin 2 receptors in the blood vessels. Calcium channel blockers are preventing calcium into the muscle cells. That leads to vasodilation as well as decreased contractility. Vasodilators, these are directly affecting vascular smooth muscle. Diuretics, these are increasing sodium and water excretion. The renin inhibitors block renin, which prevents that cascade from ever occurring. And then sympathetic blockers, these are going to affect receptors that block norepinephrine and epinephrine, which cause those sympathetic effects. And so by stopping that, vasodilation isn't occurring. Vasoconstriction isn't occurring, urinary retention, all of those things. Okay. All right. So I have a note here. I don't think this is the picture from your book, but on page 747, it shows where these different medications work. So some examples of ACE inhibitors: lisinopril, enalapril, and captopril. What do you see there? Pril, okay? Most of the time, if you see pril, that is an indicator that that is a ACE inhibitor. I'm not saying always, because I don't know why these people do the things they do. But most of the time when you see pril, think ACE inhibitor. Okay? ARBs. Some examples of those are losartan, valsartan, and irbesartan. What's our theme there? Sartan. Okay. The renin inhibitor, there's only one of these, and the name of that is aliskiren. The only way that I could tell you to remember that is the little ren at the end could help you. The calcium channel blockers are examples of that are amlodipine, nicardipine, nifedipine, verapamil, and diltiazem. I don't know why they want to be difficult on that. But the dipine can be an indicator for that, and then I don't know what to tell you about this. I actually think in the slides I have a little memory aid, and I don't remember what it is. Go ahead. You sure? um, yes, correct. Yes, I love that you are trying so hard. You are. Um, and that will, don't worry about it right this second. When we get to that slide, say your point again, because I do recognize that does help you. We'll talk about it then. Beta blockers, atenolol, metoprolol, bisoprolol, labetalol, carvedilol, timolol. LOLs, right? Our LOLs are our beta blockers. And to be fair, there are, especially labetalol, that's actually a non-selective, but we're just not going there, okay? So vasodilators, our drugs here are hydralazine, nitroprusside, milrinone, and minoxidil. There may be some little memory aid that I have on another slide. Again, I don't remember. You might just have to memorize those. The diuretics, these work in different ways. I'm not getting too deep off into this. When we go over diuretics, we'll cover it then. But there are thiazide diuretics. The common one that you'll hear of people taking is hydrochlorothiazide, which is HCTZ. Okay. Loop diuretics, like furosemide or Lasix, and potassium sparing diuretics like spironolactone. Okay? Correct. So in especially loop diuretics, hypokalemia is a huge concern. So most of the time those people have to be on a potassium supplement. Sometimes, depending on what their blood pressure is, they will prescribe spironolactone and a loop diuretic so that one's making you hold the potassium basically, but they're both can affect your blood pressure, or you take the supplement. The issue there would be remembering that, because if somebody's on spironolactone and I'm sparing my potassium, what don't I want to take? I don't want potassium because they're going to be at risk for hyperkalemia. Okay? All right, so ACE inhibitors. I've said what this does. It blocks that angiotensin converting enzyme. It's preventing vasoconstriction, decreasing aldosterone, which is decreasing the sodium, which is decreasing the fluid, which decreases the blood pressure. Okay? This is just a little helpful thing for you to remember. Some things that can occur for this. So the ACE is what it's doing basically. They end in the prill. Those are some examples of what the medications fall in that category. These are, and even in your book, I feel like they say that these are the more commonly given medications. Lisinopril is the most common ACE inhibitor that I've given. That doesn't necessarily mean anything. That could be providers. But regardless, the prill indicates that that's an ACE inhibitor. So the benefit to this is they are decreasing that peripheral vascular resistance, which is decreasing the blood pressure without affecting or increase in their cardiac output, their heart rate, or contractility. Okay, so if somebody has issues with these things already, it would be beneficial for me to not give them something that's making their heart work harder. Okay, so an ACE inhibitor would be helpful. Some effects that can occur with this: dizziness, orthostatic hypotension, GI issues, headache. A very common thing that can occur is a non-productive cough. Kiera explains why that can happen. So they develop just this hacky type cough, and some people just think it's aggravating. It just is, it becomes bothersome to them. If that's the case, then they'll try a different medication. Usually they'll move them to a ARB. The one of the biggest risks with ACE inhibitors is angioedema, which they get facial swelling, and airway is my biggest concern in that case. So if somebody develops facial swelling, what do I want to tell them to do? Stop taking it. If I just said that that could impair your airway, am I going to say just hold tight at home and you can, maybe it'll go away? No. Take some Benadryl? No. They need to stop taking it and they need to seek treatment. Okay. Um, for these are just other things that can affect. I feel like we've already went over how that works. So it does reduce cardiac workload, and it can preserve kidney function in diabetics. Trying to see if there's anything else I want to say about that. Don't think so. Okay. All right, I have another note here that on page 755, there's a table. Nope, 755, so sorry. All right, so as far as us administering these, most of them can be taken with or without food. The only exception to that is captopril. It can be altered if it's taken with food, so it needs to be taken an hour before food. Okay. If they are having surgery, they could potentially have post-op hypotension. They may need IV fluid. So that is another thing when you are patients having a procedure, getting an accurate med history on them to know what they've taken beforehand. So sometimes they'll have them hold those medications until after a procedure because they could be at risk for that. So indications when we might give these: hypertension, heart failure, diabetic nephropathy because it can protect their kidneys, and if they have left ventricular dysfunction. Times when I would not give this: if they have a history of angioedema, especially, we're just going to say period, but if that was caused by a medication, specifically ACE inhibitor or something affecting that RAAS, we would not want to administer this to them. Don't give this to pregnant people. If they have impaired renal function, they're going to need a lower dose. We also want to be careful giving this to patients with heart failure, or in patients who are hypovolemic. Another side effect, I can't remember if it was on that other slide, is hyperkalemia. So we'll monitor their potassium. Also want to teach them to look out for like palpitations or foods that contain potassium. And then with any diuretic, hypotension is going to be a huge concern because we're affecting the RAAS. If they're taking an increased dose, especially, they could be at risk for renal injury. And I'm trying to see if there's anything else specifically that I want to tell y'all. If they present with chest pain, angina, heart failure, it would be important for us to do a med history, just to make sure that that could be a complication of them taking those medicines. And before, since this is really our first specific medication, every medicine that we talk about, allergy is a risk. If you've read the back of anything, hypersensitivity is a concern. So just teach them to monitor for signs and symptoms of that. As far as angioedema, that is more common in African American patients. Trying to see if there's anything else I want to tell y'all on that. So outside of that, because it can affect their kidneys, we do want to monitor their kidney function. Okay, so I would do that by, how am I going to know kidney function? Urinary output, GFR. Did you say something? BUN and creatinine, right? So I'm monitoring their kidney function. These also can potentially cause bone marrow suppression. So when we're monitoring CBCs, we're looking at red blood cells, white blood cells, platelets, which also is going to put them at risk for bleeding, infection, anemia. Okay, so all those signs and symptoms. All right, some drug interactions with this. We said this can cause them to hold on to potassium. So if that's the case, if they're taking potassium supplements, it's going to increase their risk for hyperkalemia. Same thing if they're taking potassium sparing diuretics. And then salt substitutes like Mrs. Dash, I think is the name of that. Those are actually high in potassium. So that could be a risk. Let's see what else I want to tell you about this. Oh, if they're on other antihypertensives, obviously that's going to increase their risk for hypotension. Same thing with diuretics. NSAIDs can actually decrease how effective these are. So if somebody takes ACE inhibitors with NSAIDs, it may not work as well. If taken with lithium, it can increase lithium toxicity. With allopurinol, increased risk of hypersensitivity. And then if it's taken with other drugs that affect the RAAS, they're going to be at an increased risk for serious effects, just because those are multiplied, basically. So that is another reason why we want to ask for over-the-counter medications, specifically for the impact of NSAIDs. Okay. Question, is using a loop diuretic the first approach in stepped care management of hypertension? No, what's the first approach? Lifestyle, that's right. Diet, exercise, avoiding salt. Very good. And then what drug did I say they usually start them with? Thiazide diuretics is usually what they start with. Good job. Hydrochlorothiazide. Okay. Next, we're moving to ARBs. I might not get specific on some of these things just because these are very similar to ACE inhibitors, which makes sense because it's affecting the same system just a little further down. This is a potential alternative if they have the cough issue with ACE inhibitors, okay? All of these are given orally. They should not be given to people who are pregnant or lactating. The meds in this, here is a list of them. All of these end in that sartan, which does make it easier to identify them. And Let me see if there's anything else I want to tell you here. I don't think so. Everything else that that drug card says is in line with ACE inhibitors. Okay, so you can kind of put those together with the exception of the cough. Okay. So these are binding to that angiotensin II receptors, preventing vasoconstriction and the release of aldosterone, therefore lowering blood pressure. These can be used in just by themselves or in combination with other things. This also can be used to treat heart failure or just as a protective measure after someone's had an MI. Because in lower doses, especially, it can increase renal function. It can be protective for renal disease, especially diabetic nephropathy. I have a note here for 756 to 757. On these, I don't know if y'all remember me saying this, and I once again didn't bring my book to show y'all, but I would, if I say something specifically about a certain drug from a class, I would note that. But outside of that, your book does do a good job of going over all of the things that you need to do for each of these drug classes. Do y'all remember me showing y'all that in the back of the book? I think it says nursing considerations or something. Yes, and it says why they're getting it, what you're worried about, nursing considerations as far as you administering it, adverse effects, all those things. So that will be helpful in organizing your thoughts by each one. Don't want to give it in pregnancy, not if they have severe kidney or liver issues. It can be given with food to reduce GI distress, but it can be given without. The side effects of this are going to be very similar to ACE inhibitors, and the drug interactions are the same as well. So if I'm giving it with other things that are affecting their blood pressure or their fluid balance, then obviously that's going to increase the risk of complications. So here's just a little picture to help you remember that. All right, aliskiren. So this is a renin inhibitor. We are only talking about one medication. This works by directly inhibiting the renin, which stops that whole system. Okay. This is going to lead to decreased blood pressure, decreased aldosterone, and decreased sodium and fluid absorption or maintenance. This also contraindicated in pregnancy, so anything affecting that RAAS, we're not giving it to pregnant people, okay? They also are at risk for hyperkalemia, also at risk for angioedema. We want to use this cautiously in people who have renal issues. We need to monitor their potassium. If they take this with a high-fat meal, it can decrease the absorption. So we need to make sure that whatever they're eating it with, if they're taking this with a meal, that they need to be consistent in what they're eating when they take it. So even if they eat 6 double cheeseburgers, let's pray they're not, but if they ate 6 double cheeseburgers when they take this medication, every day they need something with the fat equivalent of 6 double cheeseburgers. Because if they take it with 6 double cheeseburgers today, and tomorrow they take it with a no-fat yogurt, the effects are going to be very different, okay? So the fat content of the meal can affect that. Lasix actually reduces the effectiveness of this. They're going to be increased risk of complications if taken with other things affecting the RAAS, and then potassium sparing can increase potassium. All right, calcium channel blockers. So these are broken into categories, which, as Kiera pointed out, kind of gives you a little bit of background of why they're named differently, okay? And just something that I have kind of put together is like the dipyridine of the ones that are the dihydropyridines, that provides correlation for the ending of those, okay? I don't know what to tell you about the other ones, but those are considered the non-dihydropyridines, okay? Um, so the difference in these, the dihydropyridines mostly just affect the smooth muscle of the blood vessels, okay? So that's what that is affecting. And so it's not having a whole lot of impact on the heart muscle or the heart function, okay? So this inotropic, do y'all know what that means? It's like the force of the contraction, basically, okay? So the negative inotropic effect would be that this is decreasing contractility. So these drugs don't really decrease contractility, okay? The dihydropyridines don't really affect cardiac contractions, more so just blood vessels, okay? The non-dihydropyridines affect the conduction or that contractility and the vascular smooth muscle, okay? So they're affecting the blood vessels and the contractility of the heart. So they are going to have more pronounced cardiac effects, okay? So they have increased negative inotropic effects, which just means these are making the heart pump less hard, okay? So it is decreasing the force of the contraction. So if you think about that, that makes sense why that next statement is true. If you already are having trouble with your heart pumping like it's supposed to, if I have heart failure, if I give them a drug that decreases the ability to do that, I'm going to make that worse, okay? So these drugs, the diltiazem, verapamil, are not indicated for heart block or heart failure, okay? There also is nicardipine and clevidipine. These are given via IV only, and that is when somebody has severe hypertension. You might also hear that termed a hypertensive crisis. Okay, so they have very high blood pressure. Most of them are given orally, and just as a general rule, we're also not giving these to pregnant people. Sometimes benefit outweighs the risk. But just let's say we're not giving these to pregnant people, okay? And again, these are blocking that calcium, which is affecting the contraction, whether that be of the vessel or of the cardiac muscle or both. Allows for vasodilation, which leads to decreased blood pressure. Other things, because we'll see these again, these can treat high blood pressure, angina, and arrhythmias. I think that's all. Okay. So these are, I'm not reading that. I've already told you how they function. So they're decreasing that constriction. They, depending on the type, have more of effect on the cardiac cells themselves, so affecting the cardiac muscle, leads to vasodilation, which leads to peripheral vascular resistance, which leads to reduced cardiac workload, which looks like a lower blood pressure. Also, the heart isn't having to work as hard, and it can relieve angina because there's not that constriction of the vessels, okay? As well as arrhythmias because it's affecting the contraction. So diltiazem is your prototype from your book. Trying to see if there's anything specific I want to say about these. I think I have this on another slide, so I'm going to go to that. If not, I'll bring that back up. Okay. These are, I put this here just so that could be helpful to you. I tried to thread little things that might help you study. This is just specific to antihypertensives, not necessarily calcium channel blockers. Again, the reason we would administer calcium channel blockers, hypertension, angina, supraventricular arrhythmias, specifically those non-dihydropyridines, and then for Raynaud's. So remember, Raynaud's was that vascular constriction, and so in the same way, that's how that's affecting that, allowing for vasodilation. So we wouldn't give these to somebody who has allergies. We wouldn't give this to someone, we wouldn't give the non-dihydropyridines to somebody with heart block or heart failure, and don't give to people with pregnancy or lactating. Again, I think I have another slide of this, so I'm gonna go to it. Hopefully I do. If not, I'll tell you what I want to tell you. Grapefruit juice, I think I told y'all this, and I judged Tina, so sorry. But grapefruit juice can interfere with the metabolism of medications, and calcium channel blockers for sure is one of those medications. So it can, if this is taken with grapefruit juice, can lead to higher concentrations of the drug, which can contribute to them developing toxicity. So we want to make sure we tell them to avoid it. Dang it, did I not have it? If so, I'll tell y'all what I want you to know. So which statement about calcium channel blockers is correct? They increase peripheral vascular resistance, they increase calcium in cardiac muscles, they cause vasoconstriction, they reduce myocardial oxygen consumptions. D, very good. Which is not a contraindication of non-dihydropyridine. That is a hard word to say. Calcium channel blockers. Hypertension, correct. That is what we want to administer them for. And which adverse effect is most commonly associated with verapamil? Very good. I'm very proud. Y'all need to study with Kiera. Okay, so here, I think I did have it. Look at me. There might even be another one. But for calcium channel blockers, our little memory aid here, their medications commonly given are at the top. And you see the little very nice day is just a reminder of what those start with, how they work. Side effects here, they're going to have a decreased blood pressure, which if I'm giving this for hypertension, great, that's what I wanted to happen. They can have bradycardia. They can have AV block, and so I would not want to give that to somebody who has heart block. They can cause a headache due to that vasodilation. They can cause constipation, nausea, and then peripheral edema. So the peripheral edema is if somebody has if somebody is taking calcium channel blockers and they develop peripheral edema, you want to tell them to report it. Okay, so they need to come in, they need to be seen because we need to evaluate to what level. It could just be, why do you think I would want to know if they were having peripheral edema? Okay, because it could just be a side effect. What else could it be? Starts with heart. Yay! So peripheral edema can be a indication of heart failure. And so if this could potentially decrease contractility, which could cause heart failure, I wouldn't want to say, it's fine, swelling's normal. Because swelling's normal could look a whole lot different to different people, right? And so we need to confirm that it could just be a side effect. They could just say it's okay, but a provider needs to make that evaluation, okay? All right, vasodilators. So these work directly by dilating or widening the blood vessels, which reduce the blood pressure. The medications in this class are hydralazine, which can be given oral or IV, minoxidil, which is given oral, nitroglycerin is given in a lot of different ways. I do know I changed this slide and so sorry. Not this one, the nitro one. Actually maybe not in this PowerPoint. That might be in we'll talk about it when we get to it. Nitroprusside is given IV only. So this is given for severe hypertension or angina, can also be used in hypertensive emergencies or hypertensive crisis, or if patients have refractory hypertension. And then in some cases, it is used for heart failure just to decrease the workload on the heart. Okay. Trying to see if there's anything specifically that I want to mention on here. I can't remember if I have this on another slide. I feel like I do. But I have this little note and I don't think I said this. The refractory is blood pressure that isn't controlled by other blood pressure medicines. Okay, so that's all that means. This unique to this medication, nitroprusside, an adverse effect that can occur from this is cyanide toxicity, which people can die from that. So this is usually reserved for hypertensive crisis, not used commonly, okay? And obviously they would want to monitor and be careful. Other things that can occur is that retrosternal pressure, palpitations, headache, and then irritation at the insertion site for nitroprusside. Again, these work by dilating those vessels, allowing for blood to flow easier, decreasing the pressure, and these do activate the sympathetic nervous system, which can cause tachycardia, which may cause the heart to have to work harder, which would be contraindicated, not what you want. If somebody has coronary artery disease, I don't want them to, their heart to have to work harder, and I guess potentially could, I don't want to say that and that be a lie, but I guess it could potentially lead to some sort of embolism or something like that. And position changes are going to be very important with this because they do work rather quickly, especially if you're talking about IV. So they could quickly lower the blood pressure and cause hypotension. In fact, with nitroprusside, it's very important that they're laying down whenever you give it to them, just because we don't want them to pass out. Here is a picture of the direct acting vasodilators, indications for when we're using them, and then pictures of how they're given. All right, diuretics. So these are given to treat high blood pressure or fluid overload, which could be a result of heart failure. There are different kinds that are used, so thiazide or thiazide-like diuretics are what we would prefer to give. Again, those thiazide are usually what we give first. The potassium sparing diuretics are used sometimes, and then loop diuretics are used when necessary. And mainly, I will say really the reason for that is because hypokalemia is a huge risk with loop diuretics. So these are going to reduce their blood volume, decreasing that peripheral vascular resistance over time, which decreases the workload, which decreases all those little microvascular changes that can occur from increased pressure over time. They also can be given in conjunction with antihypertensive medications, these are stopping or vasodilating or decreasing the fluid volume, I guess, or the mechanism itself, and then the diuretics help to get rid of the excess fluid. Yes. Mm-hmm. I've already said that. So things that I would want to monitor in these are electrolyte levels. Potassium is going to be very important. Also teaching them signs and symptoms of hypokalemia like cramps, muscle pain, palpitations, those sorts of things. And then monitoring urine output, looking for signs of dehydration, especially in patients who are at risk. Here's a little picture of hydrochlorothiazide. So they could have an accumulation of uric acid, just as decreasing that fluid. It could cause them to retain calcium, which could lead to kidney stones. Low sodium, high blood sugar, so the high blood sugar is going to be due to concentration, basically. So I'm getting rid of the fluid and there's more sugar there. Okay. And then dehydration also is a concern. Very important that I'm monitoring urine output with diuretics, knowing that they could cause orthostatic hypotension and just fluid intake too. In order for you to excrete it, you had to have an intake of fluid. This is just a picture that might be helpful to you in recognizing where those diuretics are working and kind of differentiating between what they're affecting. Not necessarily a picture you need to memorize or anything like that. All right, and then sympathetic nervous system blockers. I may or may not get into chapter 31. It's going to be dependent on how far we get in other lectures. If I don't, I'll go into more detail on these. I had left this a little vague because I've went over that chapter before, but I feel like we cover it enough that y'all will get the point, and I don't want you are having to learn a lot of medications for this test. And it's not even necessarily about medications, it's just reiterating a lot. So stay tuned on if we're going over 31. If you want more information on it in the meantime, these are spelled out in more detail in chapter 31. Okay. So the deal with the sympathetic nervous system blockers is they are affecting the action of norepinephrine and epinephrine. Okay, so they're blocking those. By doing that, and the gist of chapter 31 is those sites where those are activated or what those affect are differentiated by alpha or beta sites. So depending if it's alpha, beta, both, or if it's specific to one or the other, is going to depend on what action it releases and then also what side effects could occur. Okay? That's that in a nutshell. Basically, our goal in using beta blockers, the alpha blockers, or both, are that we are causing vasodilation because we're restricting or stopping the vasoconstriction that normally would happen. And in beta blockers, one of the biggest things that they do is they are, epinephrine. Like when you think adrenaline, what do you think? If I get adrenaline, yeah, my heart rate's up, my blood pressure's up, everything's up. So if I'm stopping that, then I'm going to decrease the heart rate, decrease the blood pressure. Okay. And so the beta blockers, or those LOLs, that's what's happening. It also affects the contractility of their heart, which makes sense because I know if my heart's racing, it's pumping faster, it's moving, it's going to slow that down. And so this is one of those times where the medications that we've talked about before this really focus more on your blood pressure, lowering your blood pressure. Beta blockers more so decrease your heart rate. Okay, so if you had to pick and your heart rate was high, beta blockers would do a better job of that, of decreasing heart rate. Okay, the alpha blockers, these are going to cause vasodilation in arteries and veins. Both of them, if they do, like the non-selective, just in general, adrenergic blockers, those are going to affect both sites. So the sites that affect more the vasculature, and then the sites that affect the contractility and the heart rate. Okay. And then the alpha 2, that is decreasing the release of those sympathetic things. Okay. I'm really trying to not get too deep off into that because I think that PowerPoint where I go over all of that is like 40 something slides. But that's the gist. Okay. And we will come back to beta blockers when we talk about other conditions. All right. So I'll make that decision at that time if I go into that. All right. So now we're moving to antihypotensives. Okay, so if I'm stopping the hypotension, what am I doing? I'm raising the blood pressure. Okay, so if somebody has shock, they hemorrhaged, they have some sort of volume depletion, severe dehydration, something where they have their blood pressure is low, then we may administer these medications. Okay. The medicines that we could give are sympathetic adrenergic agonists, okay? Also known as vasopressors. So if I just said that a sympathetic adrenergic antagonist or a blocker stopped those things, what are these doing? They're making them happen, right? So this is activating the epi-norepi. This is making that happen. One of the things, and I feel like this is a very good term for those drugs, vasopressors, because they're pressing on the vasos. Okay, so they're constricting that, allowing me to raise my blood pressure. Okay, there's not vasodilation going on. And then the droxidopa, that's a special one that we'll talk about. So those are the different kinds of these. They can be given also if somebody has hypotension after a procedure or after anesthesia, or if they have orthostatic hypotension. These are very dangerous, require careful monitoring, usually used in serious emergent type situations. Okay. They do have decreased or narrow therapeutic windows. And I think that's it. Okay. So vasopressors are critical care medications that are activating our sympathetic nervous system, which is just mimicking that fight or flight response. Okay. So think about everything that you're doing when you are in attack mode, when you are anxious, this is being activated, okay? So our heart rate, our contractility, and our vasos are constricting. So those are increased, and then we have vasoconstriction. If somebody has severe hypotension, vasopressors are our first choice. Usually indicated for shock treatment, and then it is important, this isn't going to be long-term solutions. We need to figure out whatever's going on and remedy that while we're just maintaining some sort of circulation and perfusion. A potential problem with this is because I'm causing vasoconstriction, I could cause too much of that, or if there already is an impairment, and so that could lead to issues with tissue perfusion, okay? So if they have peripheral vascular disease, that would be an issue. I'm also monitoring for arrhythmias. Most of the time, this is going to require a central line, and then they'll be titrated to when they're working. Again, we're going to start low, go slow, okay? Midodrine, this is an oral medication that treats orthostatic hypotension. It activates those alpha-1 receptors in our arteries and veins and raises blood pressure. This is going to be used when other things didn't work. They don't want to take this at bedtime. Make sure they take it 4 hours before sleep. We want to monitor for urinary retention. So if you look up a picture, and if I don't go over that chapter with you, I may at least show you the picture that I have of where those receptors are, because those alpha receptors are a part of urinary release, basically. And so if I'm impacting that, then they can't release urine. Okay, so urinary retention is a part of that. And then they also can have visual type issues. We're checking to see if when they lay down that their blood pressure is getting too high. Okay. Let me see if there's anything else I want to tell you. I think that's it on that. Okay, so side effects of these are dizziness, itchy scalp, numbness, tingling, chills, shivering, changes in urinary habits, feeling nervous, and goosebumps, which we haven't talked about a lot of those things. So those should stand out. I'm not going to go over this, but this is a picture here of kind of giving you an idea of decision making, of if the patient presents with this, when would these things be indicated? How would you make a choice one way or the other? And basically just treatment, not something you need to know. All right. So Levophed is norepinephrine, which is, I don't know why that's showing up so blurry. It doesn't really look like that on my screen. This is given for low blood pressure that's usually due to some sort of procedure or cardiac arrest. The first line drug when somebody has had cardiac arrest is epinephrine. It initiates our contractions. And I don't know. We're going to skip over what that little thing is. I was just trying to give y'all something that's a picture and not just words written on a slide that might be helpful for y'all to look at. Okay, vasopressin. This is synthetic antidiuretic hormone, okay, which makes sense. If I'm not diuresing, I'm holding on to it, okay? So I'm going to have vasoconstriction and also have fluid retention. Here's a little helpful hint if y'all can't read that. It says the ADH adds the H2O. I do feel like that is helpful. We haven't learned about diabetes insipidus yet, but that is a treatment that can be given for diabetes insipidus. not something you need to know right now. All right. Dopamine, when we give this, or dobutamine and dopamine, we give this for cardiogenic shock when our heart isn't failing the way it's supposed to. It's going to cause a better contraction, which increases blood that flows out of the heart and to the body, which increases our cardiac output and blood pressure. So these are considered inotropic or positive inotropes, where they are increasing that contractility, okay, and increasing the force. For dopamine specifically, we can give low doses of this to increase renal blood flow, which is going to help increase urine output and kidney function. So that would be when given for low doses, but at higher doses is when it's causing the vasoconstriction, okay, and raising the blood pressure. So these are helpful to treat septic shock. We want to monitor closely because it can cause heart rate, blood pressure, and arrhythmia issues. And when it is excessive, when we've given higher doses, it can decrease renal perfusion. Okay, so there is a distinction there. Another important thing with these, we want to make sure that we monitor the IV site because it causes vasoconstriction, it can cause tissue ischemia. So if I asked you if you're monitoring an IV site of something that can cause tissue death and you notice an issue, what are you going to do? You sure? Please not continue to give them, right? Now they're going to need the medication still, so we may change the site, give them, continue to give them the medication, but I'm not continuing to give it through that site. Again, most of the time these are going to be through like central lines. So dopamine is affecting the alpha and beta receptors. Again, the lower doses, it's just affecting dopamine, and the beta, which could help with kidney perfusion. As we increase the dose, that can get worse. We're looking for infiltration, and these are going to lead to increased cardiac output. So we're assessing blood pressure, vital signs. Somebody on this is going to be in a critical care unit. This isn't something you're just giving willy-nilly, okay? All right, droxidopa. This is indicated for neurogenic orthostatic hypotension. And let me see if there was anything. I should have increased the size of this. May interact with if they're taking other things that are increasing their blood pressure, like some of those drugs that we've already talked about, it could be excessive. So just be careful when you're